Are you saying that in order for somebody to benefit from these drugs, they need to be obese?
No. In fact, patients who may have just a higher risk for disease, that condition can be reversed with these agents. There's reductions in cardiovascular outcomes, so heart attack, stroke reductions. And we were able to reduce prediabetes by 90%, metabolic syndrome by 80%. We're able to take people off medicine. In fact, that's kind of the wild craze of these medicines because we know they work so well. Hi.
It's time for a test.
Sure.
No. Before you say sure, you better know what I'm about to ask you.
I don't. I do not have a clue.
No. So we get a lot of questions. And I think all things medical can be complicated to begin with, right? I mean, there's no short answer to much in the world of medicine. Mm-hmm. But I think right now, conversations about weight loss drugs in particular, and that's a very broad, generic term, but we're going to narrow it down a little bit. I think conversations about weight loss drugs are on everybody's mind and around the Thanksgiving table coming up, and I think it's important. So I thought, if it's okay with you, I thought I would ask you some questions and maybe get a little conversation going about some of the most common ideas about weight loss drugs and some of the issues that we face and maybe some things that I don't know. I want to know. I want to learn.
I'd love to teach you.
Okay.
Let's go.
Weight loss drugs aren't for everybody.
Correct.
What indicators, what do you look for when you start thinking that somebody may benefit from a weight loss drug? And let's talk specifically about the GLP-1s.
Sure. So there are medical criteria for patients who will derive benefit from these weight loss drugs. Some of those criteria are in the form of FDA indications. So the term obesity, the term type 2 diabetes. Those are the two most common FDA indications for GLP-1s or GLP-1s and GIP agonists, otherwise known as the big O, Ozempic, Wegovy.
Are you allowed to say big O?
Sure.
Right.
Semaglutide is the generic for those two forms. And then there's another drug, Tirzepatide. The generic is Tirzepatide, Mounjaro, or Zepbound are the two brand names that are on the market.
Yeah. Okay. So you say generically use the term obesity just now, right? But obesity generally doesn't begin by a medical definition until you start getting into a body mass index, a BMI of 27
plus a
30,
comorbidity, right? So another reason that places you at risk because your weight plus another indicator that you might have a stroke or a heart attack later on.
So this seems to be a really good opportunity because you specifically said FDA indications, and there is something that we refer to as off-label prescribing, and simple definition of that.
Yeah, it's super complicated because we could have a slew of patients come in and meet medical criteria for use of these drugs, but their insurance isn't going to pay for it because it doesn't meet FDA indications. And even in some cases, a patient is obese, but they may have an insurance company that doesn't value prevention or weight loss drugs. And so even though they meet medical criteria for benefit from these agents, they are not going to get it covered in their pharmacy. And that's really unfortunate.
Even before we get into the insurance conversation, though, there is a continuum of normal weight, and I put normal in air quotes here, but normal weight, overweight, obese,
yes,
morbidly or super obese.
Yes.
Are you saying that in order for somebody to benefit from these drugs, they need to be obese?
No. In fact, there have been plenty of studies and evidence showing that patients who may have just a higher risk for disease. So, for example, prediabetes, you're almost to diabetes. That condition can be reversed with these agents. There's an indication that semaglutide holds that has shown reductions in cardiovascular outcomes, so heart attack, stroke reductions. So your question was, do you have to be morbidly obese to only benefit from these medications? No. And in fact, that's kind of the wild craze of these medicines because we know they work so well and they work across a range of individuals. We at ZüP, if you were to come in to ZüP for a weight loss evaluation, we call it our cardiometabolic program because we're not only looking at weight, we're looking at what weight loss can do for your blood pressure, what weight loss can do for your cholesterol, what weight loss will do for your diabetes or your insulin resistance, what weight loss will do for your waist circumference. We look at a host of criteria that you could benefit from with that particular drug as a part of our evaluation for weight loss. And we're going to do some baseline labs and get some assessment on you. We're going to make sure that you qualify for these therapies. It's safe for you. And then we're going to meet with you weekly because another part of this equation is making sure that these drugs are effective. When you are going outside of an FDA-approved patented product or an FDA-approved generic, you need someone monitoring you so that you're getting your money's worth and that you're doing it safely and the right way.
It just makes sense. These are powerful drugs.
I have 3 short examples of patients that have benefited from our program, and each are slightly different, and I think that it demonstrates the fact that we're thinking outside the box, but we're meeting patients where they are. And one is a patient who had type 2 diabetes. His insurance absolutely covered Mounjaro, but when the shortage hit, he was only able to find his medicine, 1 month out of 3 or 4. And so we used the compounded formulation in his case to just bridge therapy so that he had sustained help. And he was able to, over the past couple of years, lose over 100 pounds with branded and compounded product combined. Yeah. His labs were always normal when we checked them, and it was not at risk. He was not at risk. And we're very happy that all of his numbers are controlled at this point in time.
Does he feel better?
Oh, yeah. Absolutely. Yeah. Absolutely. We had a young girl come to us before she was 18. Her mom had brought her, and she had real metabolic disease. She had something called PCOS, where that's a hormonal imbalance, and it ties in with insulin resistance. And she her insurance would not cover. Her labs weren't. Of course it wouldn't. Her labs weren't sick enough for her to qualify for a branded product. But over a course of several years, she also lost over 100 pounds, and really? She is metabolically stable. And those diseases that we were worried about when she was 16 are no longer present when she's 18. And we had to use compounded product in her because we could not obtain branded formulation. And then there are people, I think the most common group of people that are in our program are just the normal patient that might be, 20 to 40 pounds overweight. They've got joint pain. They're not doing things like they used to. They are feeling sluggish. They're tired all the time. They may have a family increased risk for cancer or heart disease, and that excess weight really changes their risk profile. So what you're looking for there are measurements of progress or improvement in your health, right? Mm-hmm. So what are some of the risk factors of taking these drugs? Because that's a very common question. Yeah, and I think that's a really important question to answer. When we first really noticed in the community that people were desperate to get their hands on these agents, we were having people come into the clinic that had bought unknown drug on the internet saying, hey, can you help me turn this powder into something that I can inject? And I was like, no, ma'am. No, we're not doing that. Just no. So, and we also had people who bought said drug on the internet or received it from an unknown source that didn't know what dose to give them. It weren't even given a concentration. We had no idea. And that was a dangerous flag for us. We knew that patients were seeking these agents, and particularly generic or compounded forms, or they may have even sought name brand drugs online that weren't, in fact,
They're counterfeits.
Yeah.
They're counterfeits.
Yeah.
So you have a risk of taking a drug that may or may not be the drug that you've ordered up, and we're talking about mail order or internet drugs. But how about somebody who's going to a reliable source, and that's us? What are you concerned with? What can go wrong with these drugs?
Yeah, well, first off, these drugs are not appropriate, as you said, for everyone. There are a group of people that we absolutely will not give this medicine to, these classes of medicine. If you have a history of medullary thyroid cancer, you are not a candidate for this drug. There's another cancer called medullary endocrine neoplasm 2, MENS 2 syndrome that we screen for, and we look for those things. We also are concerned with people who have history of pancreatitis, because sometimes patients who take these drugs can have a pancreatic flare. And so there are screening mechanisms, labs, that we like to get at baseline before we begin any therapy with these agents for safety reasons.
Can I bug you about a question that recurs all the time, and it doesn't just apply to the GLP-1 drugs, but it applies to a lot of drugs that are termed generic and then compounded. And I think it's very confusing, because I'll have somebody come up to me and say, "Hey, you guys have ZüpMed, and do you have Mounjaro?" And I always find it a little challenging to explain, sort of.
Sure, I can go through the difference. A brand name product is a drug, has a patent associated with it. There is a pharmaceutical company that has the rights to sell, market, produce this particular drug. But every drug has a chemical name, and that is what pharmacists refer to commonly as the generic name. Now, once drugs go off patent, they can be sold in a generic form. Oftentimes, the generic form is much less expensive than the brand name. But where compounded has come into the talk of the town, if you will, first of all, compounded medications aren't FDA approved. They are individualized. They are made by a pharmacist in a pharmacy. They are compounded under strict regulation and policies by the FDA, but that individual compounded product is not FDA approved. Why there are compounded products on the market right now, though, is that when there is a shortage of an FDA-approved product and there is no other alternative for patients to receive that therapy, by law, it is legal that a compounding pharmacy or pharmacy facility may make that generic compound so that patients are not without their drug therapy. And we're in a national shortage of GLP-1s and GIP
there was
agonists.
like 3 days that we weren't in a national shortage,
right?
right?
It's gonna bounce back and forth. It is, but for the past 2 years, consistently, drugs by the brand name Ozempic, Wegovy, Mounjaro.
So let me challenge you: is it exactly the same?
It can be, and there are federal rules that apply. And when there is a shortage, the compounded agent can be exactly like the parent or branded compound. In situations where a patient may be allergic to a brand name, then legally a compounded formulation that is different from the patented form may be made for a patient so that they can derive benefit from their therapy.
Mounjaro, it's in the Tirzepatide group, is that right?
Tirzepatide is the generic name of the branded Mounjaro.
So if I buy Tirzepatide from you, if I'm in the cardiometabolic program and I buy Tirzepatide from you.
Well, you're not buying drug from us. We are prescribing that medicine, and we are outsourcing to a state-regulated, licensed pharmacy that is making that medication specific for you.
Okay. Yeah. So is it the same as Mounjaro then?
It is a generic Tirzepatide. And so I can't tell you that it's 100% because we are not a pharmacy, but it is very close. Yes.
Okay. All right. We've been talking about shortages and the alternative of using a compounded product. But let's say that I'm in a situation where my insurance company is not going to pay for the drug and I can't afford it. and there is no longer a shortage, so I'm no longer have access to a compounded drug. What happens when I stop taking these things?
So
And before you answer that, let me just preface this and say, we used to talk about the health benefits of losing even 10%. When you and I started off together in late
25 years ago.
25 years ago, and we were on the lecture circuit about overweight and obesity, we said, look, if you weigh 200 and you take 20 pounds off, there are measurable benefits in terms of your blood pressure, your blood sugar, your longevity. So now we're talking 20%. You can lose, and I saw the ad last night, lose up to 20% of your weight. So what happens when I no longer have access to this drug?
Yeah, there's a couple of concerns and a couple of things that we do at ZüpMed that are specifically and intentionally to help stop that regain. So to answer your question, black and white, in the clinical trials of these agents, patients were enrolled who had type 2 diabetes or obesity. When they stopped taking the medicine at 5 years, 7 years, however long the clinical trial was, they regained their weight. Some of them regained all of their weight. Some of them regained 2/3 of their weight. So it's a real issue. We know that obesity is a chronic condition that is going to require some type of therapy. When someone enters our cardiometabolic program and let's say we reach that weight loss goal, that 10%, that 20%, that gives you all of the benefits of you no longer have to take your blood pressure medicine. Oh, look at that. Your cholesterol is now normal. Let's back off on your statin. Or you are now at a healthy weight. I want you to stay there for lifelong health benefits. What we've done is transfer that patient to a maintenance kind of a dose. And we do a couple of different things. We do back off on how often we give these medications. Generally, it's recommended that someone take them every week. We have had success in extending that time period. So let's say a patient may give it every 2 weeks because they're at their normal weight. And we're trying to find a lower dose or a less intense regimen that keeps them there. We also believe that a lot of weight loss, metabolism, gut health plays a huge role in the success of long-term maintenance. And so if you're a patient of ours at ZUP, we're going to be targeting specific probiotics that are known to fuel your metabolism. We're going to be talking to you about lifestyle choices and protein intake and water intake and fruits and vegetables and the things that we know are going to benefit beyond just weight management alone.
Is it true? Is it true that some people actually start to crave better quality foods? I mean, when they're on these drugs, or is that just myth?
No, that's actually it's really interesting because pharmacologically these drugs work not only in the gut but they work in the brain. And talk about a super complex, algorithm because there are hormones that make you hungry. There are hormones that make you not hungry. Yeah. There are hormones that make you want to move. But in essence, these drugs, and I've heard this time and time again, they just quiet the food noise. They quiet the alcohol cravings. They quiet the eating behaviors that are detrimental, those tendencies. And they work. And in doing so, I mean, we still have to eat, right?
Yeah.
So our bodies naturally go towards what is going to benefit us and those fruits and vegetables and proteins. The junk food, the alcohol, the binging go away.
Yeah.
But they're replaced with
that's a very real thing,
yeah,
right? I mean, it's
yeah.
a very real thing. We do get those cravings. Like, I have got to have something sweet. I need a bag of potato chips. I've got to have something salty. And that's our body, through the transmitters we call hormones, saying, hey, you need to eat this because for one reason or another, we need to boost up or decrease something going on.
Yeah, and there's a lot of people that would say those hormones in the gut are regulated by our microbiome. So there's a lot of talk in the weight loss industry about probiotics specifically, and there's more to come. We've got a lot to learn, but there's something there.
So if I can preach. You said one thing that really I think is so important. We don't treat high blood pressure, hypertension, with the idea that let me give you this pill. I'm going to cure your hypertension. It is a lifelong problem. We don't understand it. We know some of the mechanisms, but we don't understand why they occur in people. We know it's a commitment to treat your high blood pressure. We know it is a commitment to treat your blood sugar when you have diabetes or even prediabetes. Mm-hmm. We know it is a lifelong commitment to do so. And we can name any number of chronic diseases, including now obesity. This is not something where, hey, I'm going to go out and eat fresh fruits and vegetables and run, and I'll never be obese again. Because we know that's not the answer. And I think we need to accept that needs to be treated no differently than any other chronic disease.
Yeah.
I am not shameful that I have high blood pressure. I am not shameful that I might be pre-diabetic. Not telling you anything about my health here, okay?
We might need to talk after this is
No,
over.
I think we're good.
Yeah.
But I should also not be shamed by my obesity because it is a chronic disease that needs addressing. And
If I were to change one, actually, I would change a lot of things about our current healthcare system, but let me just talk about the GLP-1s for a second. These are phenomenal agents. In our previous medical experience, there have never been medicines like this that truly have changed the landscape and changed the cardiovascular risk profile of patients, the diabetic risk profile of patients. But man, oh man, I wish I could get insurance to cover it for so many other people. And it's not like you wake up one morning and have type 2 diabetes. We know years in advance that your insulin resistance is getting worse, your A1C is getting worse. There are so many patients who could benefit early. And actually, we published some of our data from using the compounded formulations in people because there was a national shortage, and we were able to use off-label these agents in those who were pre-diabetic or those who had this constellation of symptoms called metabolic syndrome. And it's a combination of high blood pressure, high cholesterol. Your waist circumference was a little larger than it was at age 18. There are some cutoffs that we look for, but your triglycerides might be a little high. But we took those patients who kind of were in the middle. We knew that they were at risk, and we went on ahead and preemptively prescribed these agents, and we were able to reduce prediabetes by 90%, metabolic syndrome by 80%. We're able to take people off medicine. I mean, these are incredible agents that if insurance would cover them earlier, America would look a lot differently than we do right now. 2/3 of Americans are overweight or obese. That number is high in our children as well. We've got a long way to go to help our nation be healthier. I'm thankful for these agents. I'm thankful that we have our program, our cardiometabolic program. We're going to make a difference in those people who are at risk.
thinking globally, acting locally.
Yeah, I like that.
Yeah.
Yeah.
Fun talking.
Thanks.
Love you.
Love you.